Good morning, everybody, and a very warm welcome, and it is a warm welcome, particularly to those of you in the South, to today's online event on patient safety. This is run by HQIP, the Healthcare Quality Improvement Partnership, and we're scheduled to end at noon today. My name is Jacqueline. I'm a Medical Director and Deputy Chief Exec at Harrogate and District NHS Foundation Trust, and I'm also a trustee of HQIP. And first things first, as always in these events, it's for you to note that we are being recorded today, and we hope we're going to be making the slides and the recording available on HQIP's website in due course, because we've got lots and lots of fantastic speakers with lots of information to digest, and we know there'll be a number of people watching back. This event is part of Clinical Audit Awareness Week 2026. A week-long campaign, which we're in day 4, it celebrates and promotes the critical role of clinical audit and data in improving healthcare, and importantly, improving experience and outcomes for patients. The campaign also includes the Excellence in Clinical Audit Awards, which recognises individuals and teams who are transforming healthcare through rigorous clinical audit and evidence-informed improvement projects. And well done to all the winners. I'd like to start by saying a huge thank you to all of you who've taken the time to join us today. I can see the numbers are almost at 200, but most importantly, a huge thank you to today's speakers who will introduce in due course. This week, across 5 theme days, our 2026 campaign explores how insight becomes action. We've been showcasing practical examples, innovation and collaboration to support improvement across healthcare. Today's theme is patient safety, extremely relevant, I think, with the communications that have been going out this week. It's all about the essential role of robust data and learning from audit, how it helps to identify risks, prevent harm, and build safer systems of care. Next slide, please. So as always, we have to do a little bit on housekeeping. This is a Teams webinar, so we have auto-muted all of your mics to avoid any background noise. Cameras are on, so if you do have a camera function, it would be lovely if you could turn it on. I know as a speaker, it's always nicer to speak to lots of smiley faces than little boxes, but appreciate not all of you will have cameras. The chat function has been turned off for this event because we're using the Q&A function, which you'll see at the top of the screen. We've got great speakers. We have got some time for questions. So if you do want to pose a question, pop it in the Q&A box, and our comms team will be scanning that, and we'll be selecting a few questions to ask our speakers all together at the end of the session. We won't be taking individual questions in the interest of time. I'm sure most of you know how to use Teams, but just to remind you that the browser versions of Teams works better than the app to get the full Teams webinar experience. So if it's feeling a bit clunky and you're not sure, try switching to the browser version. If for some reason you can't access the Q&A and you want to ask a question, then on the HQIP website, there's a Contact Us form, and we'll be scanning that as well. And we'll do our best to answer all questions that come in following the event. If there's any technical difficulties, as there sometimes can be, I'm sure we all know, and the webinar ends earlier than expected, please wait around 30 seconds and then rejoin the webinar either by clicking the rejoin button or via the original joining link. But hopefully we won't need it, but just in case. And finally, before we get into it, it'd be great if people could share, if they're on social media, about the events of HQIP and Clinical Audit Awareness Week on your social media platforms, either things that you're doing in your own organisations or things that you've attended and that you've enjoyed or what lessons you've learned. We've got a hashtag CAAW26 if you want to use it, because we really want to spread the word on the importance of evidence-based healthcare improvements. So now I'm going to hand over to our first speaker. And I'm sure she needs very little introduction. We have Professor Henrietta Hughes OBE, who is the National Patient Safety Commissioner and has worked in this space for many, many years. She's going to be talking about her perspective as a Patient Safety Commissioner on using data for safety. So over to you, Henrietta. You've got 20 minutes. I'll give you a little hands up nod at 3 minutes to go, if that's okay.
Thank you so much, Jackie. And I want to say a big thank you to everyone at HQIP for putting on this week. It's fantastic and so great to see so many people joining the webinars. So I wanted to just think a little bit about how listening to patients can really then bring policy into action to improve outcomes. And I'm going to be focusing on a little bit about the background to my role, of the patient safety principles, thinking about medicine safety, Martha's Rule, and the National Commission into the Regulation of AI in Healthcare, for which I'm the Deputy Chair. So it's really quite a diverse range of hopefully quite interesting areas of policy. Next slide, please. So my role was set up because patients hadn't been listened to, and as a result, they'd come to harm. My role is to promote the patient safety and the value of listening to patients in relation to medicines and medical devices. I'm a public appointment, so I'm directly accountable to Parliament. I'm one of the few independent voices, I think, in the healthcare system. And I have special legal powers to request information and also make recommendations to the system. And I'll be talking about some of the recommendations that I've made and the changes that have happened as a result. Next slide, please. So I want to put this in the context of the patient safety principles. This is really a distillation of listening to hundreds of patients, thousands of patients and their experiences, and a public consultation that we did. And I think that if we had these principles in place and followed consistently across healthcare, that we would really avoid many of the harms and healthcare scandals that we're seeing currently. So the principles are simple: create a culture of safety, put patients at the heart of everything, treat people equitably, identify and act on inequalities, identify and mitigate risks, be transparent and accountable, and use data to drive improved care and outcomes. And if we go to the next slide, I really want to focus on this principle of using data to drive improved care and outcomes. Next slide, please. So when I think about medication safety, we have many areas for improvement that we could look at. There are estimated to be 237 million medication errors every year in England, of which many of those don't cause harm, but it's identified that around 700 deaths are caused through medication harm, and maybe even more than 22,000 deaths could be attributed to mistakes. And I'm sure that those of you on this webinar today, like myself, as I'm a prescriber, I'm a GP, I don't get it right every time, but what we need to have are systems in place to support us so that we get the right outcomes for patients. Next slide, please. And when we think about the burden of adverse drug reactions across the OECD, it's thought that this is around $54 billion a year. And that's an opportunity cost because this is money that could be spent on better healthcare for patients, but it's also obviously the impact that has on patients and families and the intergenerational harms that can occur through adverse drug reactions. Next slide, please. So I wanted to talk about a recommendation that I made for the safe use of the most potent teratogens in England. And this was because you may be well aware of the impacts of valproate, which is a medicine that can be used for epilepsy, for migraines, and for bipolar disorder. But given that pregnancy can cause severe harm to the unborn child, physical harm, but also impact on learning and also on neurodiversity. So a lot of children who are exposed to valproate in utero have autism, ADHD, and learning disabilities. So when I came into post, there were still 17 babies in a 6-month period that had been born exposed to valproate. And I made a recommendation to NHS England to improve the overview of the most potent teratogens across the whole patient pathway by the ICBs. And I'm really impressed with the work that has been done and the impact that this has. And you can see now that in the last 6 months that were measured, there were 2 pregnancies with valproate. And that may be for reproductive choice, or it may be that this is the only medication that is safe for the patient to take. I wanted to flag this because this is, I think, the impact of audit. We do audits because we think tomorrow can be better than today. And so if you've been involved in this, I want to really just say thank you so much, because the impact that this has, the numbers of babies that have been saved from a lifetime of disability and those families, is really impactful. I think this is the best in the world. We are the best in the world when it comes to the safety of valproate in pregnancy. Thank you very much. I saw the reactions there. It's not me, it's everyone who's done the work. Next slide, please. So the next policy area I wanted to talk about was Martha's Rule, and there is a video here, and thank you so much to Tina for pausing that video, because I don't want to use the time this morning on that, but please do watch it yourselves. It's on the NHS England website. The person in this video here is Mary Mills, the mother of Martha Mills, who called for Martha's Rule to be introduced after the tragic death of her daughter, aged 13, from sepsis. And working with Mary and her husband Paul, but also with health leaders from across the system, I made recommendations to the government on Martha's Rule, including ensuring that all patients were asked on a regular basis whether they were feeling well or ill. As a GP, I would have thought that would be happening anyway, but also that to give staff and patients and families the opportunity to call directly to critical care outreach if they were concerned about deterioration. And next slide, please. The data has been really dramatic.
My name's Mary Mills, and I'm
just go
Martha's
straight
mum.
on to the next one. Thanks a lot, Tina. So the data has been really dramatic. I think there was some skepticism across the system about whether this was going to be effective, whether patients knew whether they were well or ill, and whether this was going to be an opportunity cost for people who really needed critical care. Well, I think what we can show is that the people who really needed critical care were able then to pick up the phone, or their family member or a staff member. So this is quite a busy slide, but there were 13,500 calls to Martha's Rule, and within those 4,336 related to acute deterioration. And of the 2,500 calls that required a change in treatment, around 600 resulted in transfers of care to high dependency, to ITU, back to theatre, to interventional radiology, or to other services. And it's thought that around 600 lives have been saved through the use of Martha's Rule. But I think what's really important here is that it's not all about acute deterioration, but it is about communication. So in the last paragraph, you can see that over 3,000 calls led to clinical concerns around medication delays or investigation delays, and around another 3,000 helped to resolve communication and discharge planning issues. Having this data, and the data was collected by NHS England and the providers, I think is really important, because it gave us the information to say this is working and it's now a standard of care, so it should be in place in all acute services. Yesterday, it was announced that it's going to be extended to maternity, which I think is really important, that, mothers in labour, families who have concerns about acute deterioration can also pick up the phone. And the other aspect, which I think is really important here, is to think about what's the underlying cultural change which is needed. My recommendations were 3 bullet points on a page, but underneath that was a whole a massive paragraph thinking about all the barriers that needed to be overcome so that we didn't need to have, Martha's Rule in place. But I'm really pleased about the progress that has been made in this area. And I just want to thank you all for the work that you've been doing to make this possible. Next slide, please. So on to something completely different, as they say. This is about looking forwards. So the National AI Commission was set up by the MHRA to really support the MHRA in terms of changing their regulations around the use of AI as a medical device. So the regulations were last updated in 2002 when a device, and now I'm not going to be talking about National Joint Registry because I know we've got that from Chris later, but a device was something like a hip joint. You know, it looked like a hip joint in the box, it looked like a hip joint on the X-ray, and it still looked like a hip joint later on. But now AI is something which can change. It can change in terms of its clinical context, there's drift, and we want to make sure that a device that's coming onto the market isn't just safe at day one, it's safe at day 1,000 and further into the future. So we've been working with academics, with tech companies, with 4 nations, with health system leaders, providers, professionals, and patients all the way through since last September to think very much about how do we ensure that the AI that is used is safe, fast, and trusted. So if I go on to the next slide, please. So we have had a cross-government working group, we've had a devolved administrations working group, the health systems working group that I've been chairing, and then the technology working group. These have all been feeding in to the main commission as we consider the 5 pros approach, which is about the product, which is about the producer, the provider, the professional, and also proportional risk, depending on, you know, the device and the conditions that are being used. Next slide, please. But we've also done a very major research and engagement program where we have had a call for evidence from patients, the public, and from investors, academics, and system partners, targeted engagement with the Health Foundation, with deliberative sessions, in-depth workshops with underrepresented groups such as unpaid carers and people with a learning disability. Stakeholder engagement, including Royal Colleges, many organisations, and also providers, thinking very much about what this means for different groups of people in the system. Direct public engagement with surveys and also with the MHRA Patient and Public Committee, and also thinking about the MHRA's AI airlock. So we have real world innovation and regulatory insights from those programmes. We published 2 reports just to coincide with NHS Confed on the 11th of June. One was the results of our call for evidence, and the other was the research and engagement report. But the whole point about doing this, the commission has been about making it really transparent. So if you're interested, you can go online, you can have a look at the Ask Me Anything webinar, which I did with Lawrence Talon, the Chief Exec of the MHRA, and Alistair Denniston, the Chair of the Commission. But also we have all the minutes of all our meetings published. This is because this is not about developing policy in a room somewhere. This is about doing this in conjunction with the whole health system so that patients, the public, and the staff feel really that they can trust the AI when it comes into place, and that the developers can also trust the regulatory processes as well. Next slide, please. So listening to learning, how have we taken this on board and how are we using this in the commission? So the common themes from across the research and engagement activity show that despite the diversity of perspectives, there was quite a lot of agreement on the conditions required for AI to be adopted safely, effectively, and with public confidence. The first thing is that trust. So they say that trust arrives on foot and leaves on horseback. If only of you remember care.data, we know that the deployment and implementation of digital in the NHS doesn't have a fantastic track record or history in terms of building trust with the public. So what we wanted to do was have that transparency that leads to trust. And if you remember back to the patient safety principles, transparency and accountability is one of those principles. The other thing that was really interesting is that support from the public is conditional. They like the idea, the public like the idea of AI being used to support clinicians, but not to replace clinicians. The third one was that the regulation must evolve. Everybody agrees that the current regulations need to be updated, but they're not well matched to AI and other digital devices. But it wasn't to have a whole complete overhaul. It was saying, let's start from where we are. The fourth one, which I think is really important when it comes to audit, is around life cycle oversight. We need to make sure that we have really effective monitoring, evaluation, and reporting of concerns. The fifth one was that the context shapes the risk. So the real world performance is really important. If a model has been developed using data that doesn't match the population that will be used in real life, we may get different outcomes. And I think this is a really important aspect, which feeds into the transparency and accountability. How do we know the data that the model has been trained on? Where are we going to have those visible safeguards, and how will, the public be able to build that trust? The final one is around equity and inclusion. And again, this very much matches with the patient safety principles about equitable outcomes and identifying the risks of health inequalities. So fairness must be considered throughout the life cycle as well. And that's why it's so important that we have really good reporting, that we have really good monitoring and audit as AI gets deployed across the NHS. Next slide, please. So from learning to leading, this is about a life cycle approach here. We first of all develop, then evaluate, deploy, monitor, and improve. And if AI systems are evolving over time, then we need to think about whether our current oversight systems are fit for purpose, whether they need to be beefed up, whether we need to be reimagined. And I think that's something which is really important for HQIP and for those who are conducting clinical audits in the future. You may be using AI to help you with your audits. You may be evaluating AI. You may be auditing whether people have had the training that they need for AI. There are lots of opportunities, I think, which I'd really like you to consider. Don't just look at what you've got in your program now. Think, what should your program look like in 5 years' time? Next slide, please. So I have done the service that I promised to do earlier, which was to speak fast and to give a plenty of time for Q&A later in the programme. I know I've covered quite a lot of different areas, but I'm really happy if you wanted to get in touch through my website. The QR code is here, and there's lots of other areas that you may find interesting, not only in terms of how we listen to patients and put that into action, but also in terms of how we think about the future and where audit fits into that as well. So thanks very much, and I'm back to you, Jackie.
Thank you so much, Henrietta, for getting our webinar off to such a flying start and keeping to time to bonus. Wow, so many great information, rich data there, and so keep the questions coming. Just a little reminder for anyone that joined late, we won't be doing any hands up. It's all through the Q&A function. So if you do have a question, please post it there, and we'll take questions at the end of all 5 of our presenters. We will have time for questions. And as we said, if we don't get through them all, the speakers have very kindly said that they'll take them away and respond, and we can post them on the HQIP website. So do keep the questions coming. So thank you very much, Henrietta. Now over to our second speaker, who is Chris Boulton, Director of Operations at the National Joint Registry, which I'm sure many of you will know is the largest orthopaedic registry in the world. So a real exemplar for how to do registries. And he's going to speak about the role of the NJR in patient safety. Over to you, Chris.
Thanks, Jackie. So good morning, everyone. I'm Chris Boulton, Director of Operations of the NJR. So today I want to talk about patient safety, but I want to look at it from the perspective of a national registry. Most of us think about patient safety in terms of the decisions made in front of patients every day. We think about diagnosis, treatment, and surgery. NJR contributes in a different way. So our role is to collect information from across the NHS, understand what that information is telling us, and to make sure that that learning gets back into the system. So sometimes that's going to mean that we're identifying an emerging issue. Sometimes it means giving clinicians confidence that an implant that they choose is performing well. And sometimes it's providing evidence that changes guidance or influences research. The registry doesn't improve patient safety through one big intervention. It improves it by steadily building knowledge over time and making that knowledge available to the people who need it. And that's what I want to talk to you about today. So I'll start with a little bit of background about the NJR, then I'll explain how we use the data we collect, And then I'm going to show you 3 examples where the registry's made a real contribution to patient safety. Next slide, please. I'll keep this fairly brief because I'm conscious that many of you will already know the NJR. We were established in 2003. Today we contain records relating to more than 4.6 million joint replacement procedures. Every year we receive information from hospitals across England, Wales, Northern Ireland, the Isle of Man and the Channel Islands. And that information covers the procedure itself, the implants that were used, and the outcomes that follow. So a lot of people think of the registry in terms of our annual report, and we're very proud of that annual report, but it's really just one of the outputs that we're producing. So throughout the year, we're analysing data, supporting research, responding to questions from clinicians, providing information to hospitals. We work with the regulators and continue to build the evidence base around joint replacement surgery. The NJR has grown enormously over the last 20 years, but the purpose has stayed remarkably consistent. We collect reliable information. We understand what it tells us, we share that understanding, and we use it to improve care. And everything we do grows out of those 4 steps. Next slide, please, Tina. So that brings me to our mission. We record, monitor, analyse and report on the outcomes of joint replacement surgery to continuously enhance patient safety, support surgeons, assure value, and improve patient outcomes. And I like this statement because it describes the whole life cycle of the registry. So recording is about collecting complete and accurate information. Monitoring means understanding what happens over time. Analysis is the bit where we're turning the data into evidence. And reporting is how we make sure that the evidence reaches the people who need to use it. So if any one of those stages is weak, then the whole process becomes less effective. Good analysis needs good data, good decisions need good analysis, good outcomes absolutely depend on the system making good decisions. So patient safety isn't something that sits at the end of that process. It's the reason the process exists in the first place. Next slide, please. So I think this slide probably sums up the NJR better than anything else. Healthcare's become really good at collecting data. Almost every part of the system now is producing huge amount of information. The difficult part is understanding what that information actually means. So for us at NJR, everything starts with data quality. Before we analyse everything, we need to have confidence that the information coming into the registry is accurate and complete. Only then do we start asking questions of the data. So some analyses are planned well in advance, others happen because someone's spotted something that worries them. Sometimes the question is very simple. Has this changed over time? Why are these outcomes different? Is this what we expected to see in terms of performance? Sometimes it's more complex, but those analyses are discussed with clinicians, statisticians, and they all become part of the evidence base. And then that evidence base finds its way into lots of different places. So our annual reports, as we've mentioned, but also research papers, continuous feedback of data to hospitals, and then into professional guidance from the orthopedic profession itself, regulatory discussions with regulators, notified bodies, with industry. A consequence of that is sometimes the impact is immediate, but more often it develops gradually as more evidence accumulates and practice evolves alongside it. And I think that's one of the interesting things about patient safety, is that big changes are actually quite rare. Most improvement happens because lots of small pieces of evidence gradually build a clearer picture. So registries and clinical audits is one of the ways that picture comes together. Next slide, please. So everything I've described so far leads into the practical work of the registry. So there are 4 main ways the NJR contributes to patient safety. The first is surveillance. We're continually monitoring implant performance and patient outcomes as new information comes into the registry. The second is feedback. We publish national reports. We provide information back to hospitals and clinicians so they can understand outcomes and trends. The third is research. So registry data has supported hundreds of published studies answering questions that simply can't be addressed without this sort of long-term national data. And finally, collaboration. The registry works closely with regulatory bodies, the MHRA, the CQC, with NHS England, with Royal Colleges, specialist societies, and each organisation brings a different perspective and a different responsibility. And in all those conversations, the registry's contribution is the evidence, the data. So the next 3 slides I'm going to show those different roles in action. They're quite different examples, but together I think they give a good picture of how the NJR contributes to improving patient safety. So the first looks at surveillance. The second looks at how evidence supports changes in clinical practice over time. And the third looks at how registry findings can contribute to a practical intervention that supports safer surgery. So this first one is probably the one people know the NJR best for. A big part of our job is understanding how implants perform once they're being used in everyday clinical practice. So every year, another few 100,000 procedures are added to the registry. And as those patients are followed up, the picture becomes clearer. We can see how different implants perform over 5 years, over 10 years, and now up to 20 years. And most of the time, that data is reassuring. Most hip and knee replacements now last well over 20 years, and patients' function and quality of life are vastly improved. But sometimes it does raise questions, and the metal on metal hip recall of 2010, that's probably the best known example. So just some context to that, most hip replacements consist of a metal stem that fits into the thigh bone and a ball that moves inside a cup in the pelvis. It's a so in a traditional hip replacement, the moving surfaces are usually metal moving against plastic or ceramic. In a metal on metal hip replacement, both moving surfaces are made from metal. So the idea was that the implants would be more durable, especially for younger, more active patients. But as the implants moved, tiny metal particles could be released through normal wear. And in some patients, those particles caused inflammation and damage to the surrounding tissue. So in 2010, there were concerns about our higher than expected failure rates. And that led to the global recall of the ASR hip system. And NJR data played an important role in identifying that metal on metal implants were performing less well than expected. Importantly, this wasn't a conclusion that was reached after one analysis. The picture developed over time as more data accumulated. But as confidence in the findings grew, that information became part of wider discussions that involve clinicians, regulators, and manufacturers. And that same process is happening right now in the NJR. Every year, more data is added. Every year, patients reach another point in their follow-up. So our understanding of implant performance becomes stronger, and we're continuing to feed information to regulatory authorities, to industry, to make sure that decisions about implant choice are based on the best available evidence. Next slide, please. So this example looks at something quite different. So instead of focusing on one particular issue, it shows what happens when evidence builds over many years. So this graph it's a bit busy, but what it shows is that revision rates following primary hip replacement fall over time. And there's no single reason for that. Joint replacement surgeries changed considerably during that period. Implants have evolved, research has answered important questions, and clinical guidance has developed. And all throughout that process, the NJR supported progress by providing information about outcomes. So our annual reports have tracked implant performance. Hundreds of researchers have used registry data to investigate important clinical questions. Professional societies have drawn on registry evidence to produce guidance. And hospitals and surgeons have been able to review their own outcomes against national data. None of those things change practice on their own, but taken together, they help the system make better clinical choices. And when you stand back and look across 20 years, you can see the cumulative effect of all those decisions. And I think that's what this graph really captures. Next slide. So the final example starts with a relatively small number of cases involving incompatible prosthesis combinations. They were uncommon, but they highlighted an opportunity to reduce the risk of avoidable error. So the NJR identified the pattern. The next step was understanding why it had happened and whether something practical could be done to prevent it happening again. That work involved the NJR, the NHS, the MHRA, and the HSIB, as well as clinical colleagues around the country. And one of the outcomes of that process was the NJR implant scanning interface. So that system scans the implant barcodes during surgery and checks that the selected components are compatible before they're implanted. So it's a relatively simple idea, but it adds another check at a point where it can make a real difference. I really like this example because it shows that publishing an analysis isn't the end story. Sometimes it's the starting point. The evidence raises a question and people work together to answer it. The outcome is a practical change. It supports safer surgery. And that's a good illustration of how the registry contributes beyond collecting and reporting data. Next slide, please. So looking across those three examples, what do they tell us? Well, the first is that patient safety takes many different forms. Sometimes it's about identifying an emerging issue. Sometimes it's about helping practice evolve over time. Sometimes it's about contributing to a completely new safety intervention. The second is that good evidence is rarely produced by one organisation working on its own. The NJR works with clinicians from all around the country, as well as hospitals, researchers, regulators, professional societies, and each has a different role. Together, they create a system that learns from experience. So I think these examples show why registries remain so important. Every year we collect more information, every year our understanding becomes stronger, and every year that evidence helps answer new questions. And so that's how registries continue to evolve and continue to feed into these patient safety conversations that are happening up and down the country today. Next slide.
Chris, just to say, this is your 2-minute warning.
Oh, it won't be 2 minutes, I promise. So I'll finish with one final thought. So the NJR now contains more than 4.6 million records. Every one of those records represents an individual who's voluntarily given us their data to improve our understanding of joint replacement surgery. The value of the registry isn't measured by the size of the database, it's measured by what we learn from it and how we take that responsibility that those patients have given us and translate that into learning to improve care for the next patient. Thank you very much.
Thank you so much, Chris. Another fabulous talk, making my job very easy, keeping to time as well. Lots of you, when you'll have time to read the comments and questions, but lots of people saying what a great national example the NJR is. I know as a medical director, it gives me enormous assurance. to know that, you know, multiple agencies are working together around this topic. So it's just a great example. Lots of things we can learn from it. Thank you so much, Chris. Okay, we're on to our third speaker, who is Faith Shields, Director of Midwifery at the Northern Care Alliance NHS Foundation Trust. As we referenced at the beginning of the webinar, I'm sure many of us started last night reading another very sobering report on maternity services, this time from Nottingham. So really good timing to get your thoughts, Faith, on using national maternity data to drive patient safety improvement. Thank you.
Thank you, and good morning, everyone. So what I'm going to do is basically tell the story of the NCA around our maternity services and how we've used data to drive improvements within our organisation. So I joined the organisation in 2022 as Director of Midwifery, and at a very similar time we were flagging through Embrace data for high levels of mortality within our maternity services. And what we recognised is that there was a significant amount of work for us to do as an organisation within the service to firstly understand what the data was telling us, but also to understand where we are now, because you will appreciate 2022 data was published that relates to our mortality data in 2020. So we started setting up mortality review meetings and really began to seek support around us understanding our data and using the real-time data tool through Embrace with our colleagues. We recognised that we would also be flagging as amber and red for 2021 and 2022. So we knew that there was a consistent pattern where mortality was a concern. So if we just move through to the next slide, please. So what we did in 2022 is launch an additional phase of our maternity improvement programme. And what you'll see here is that data is fixed very hard in terms of us understanding our core issues and building the foundations. What was very clear is that we couldn't make the improvements unless we truly understood what our data was. And you'll see within this slide, some of our strategic work streams were around people and culture, clinical governance, safe staffing and training, and engagement and equity. And for those of you that did read and did hear in the news yesterday regarding the outcomes of the Donna Ockenden review at Nottingham, some of these indicators will be very similar to that report and what have been found in other reports. So I think it's fair to say that there are issues across lots of maternity services within these areas, but what's important is understanding what the issues are and then understanding the data to drive that improvement. Next slide, please. So the Maternity Improvement Board was set up with an independent chair, which was really, really supportive in terms of that external oversight. And we did also at the same time commission an external review of our services through an organisation called Niche, who again supported us with data. We also engaged with HQIP and did a lot of work around making data count and ensuring that we were supporting our teams to understand data, because whilst data was there, the interpretation of that data sometimes was challenging. But what I do want to recognise is most clinicians are not data analysts, myself included. So whilst data was presented, really being able to interrogate that can be challenging, and I think that needs to be recognised. So the support of BI colleagues, data colleagues is absolutely fundamental to driving improvements through data. And you'll see there's a number of phases that we went through as part of our maternity improvement programme from kind of early 2022-23, where we launched phase 2, and then through to 2025. So it wasn't a 12-month programme. It absolutely wasn't a quick fix. And at the end of the programme, we did have in the region of 32 recommendations that we needed to implement on the back of the niche review as well. And what's really important is that we implemented those recommendations, and then niche came back to quality assure that we've done what we said that we would do. And not only had we made the improvements, that the improvements have been sustained, which is the real value of testing that and having that data analysis. So next slide, please. So these are the work streams, and it was important that we focused on the whole clinical pathway, and these are the areas that were particularly focused on for our improvements. And you'll see again, you know, there's very clear links here to the report yesterday from Donna Rockington around engagement, equity, understanding our population, safe staffing, people and culture, and clinical governance. So they're all things that we focused on as part of our maternity improvement programme. Next slide, please. What you'll see on this slide is the importance of making the data count, and you'll see our stillbirth rate here from April 2023, you know, graded on an SPC chart, and where we got to in October 24 before the programme was actually even finished. So very quickly we saw some significant improvements, and that really helped the team having the data to provide focus on keep going. We are doing the right thing. You know, the things that we are doing are making a change. And all of this information was shared widely with the teams, you know, right down to everybody that works in the organisation. But more importantly, all of this data was fed up to Trust Board. So the Trust Board having oversight of our maternity service and having assurance around the improvements that were being made and understanding that data was also key to some of our successes. So we had really, really good engagement and support from our Trust Board in terms of that improvement for maternity services. So that just gives you kind of a snapshot of the maternity improvement programme. But if we just move on to the next slide, what I do want to talk about is people understanding what good looks like. And it is about leadership. It is about culture and capacity and capability, but it is also about systems and processes. And that's why it's really important to bring the whole team together. And I think my 3 takeaway messages from our journey, just kind of in summary, is be curious. Don't just take things at face value. Secondly, use your data and use your data well, and make sure that you've got the right people to support the analysis of that data. And then thirdly, be brave, because none of this is easy, and it is really challenging sometimes. But we have to challenge ourselves as leaders to ensure that we're making the right changes and that we're doing it for the best reasons. And, you know, my philosophy is we are absolutely here for the women and the families, and we have to make it better. And we can only do that by being brave in the actions that we take, some of which, as I say, can be really hard and controversial, and we challenge the status quo, but that's absolutely the right thing to do, and that's what our women and families deserve. So that is, you know, the 3 kind of take-home messages. Just move on to the next slide. I think it's also important that you understand your population. So Northern Care Alliance serves a population which is extremely deprived. So 66% of our women and families come from the most deprived quartile. And the majority of our women are from diverse populations. So you'll see there kind of the England and Wales diversity statistics, and what we see within the NCA. And what we know is health inequalities do exist, and they are unfair and they are avoidable. And then again, we've got to really challenge ourselves around diversity, ethnicity. We've got to challenge ourselves around racism within organisations that exacerbate health inequalities. What are the compound risk factors for our women? What do we know about what their compound risk factors are? So within our population, not only have we got diversity in terms of ethnicity, we've got huge pockets of deprivation. Those 2 things together do absolutely have the risk of health inequalities, and if we don't acknowledge that as an organisation and flex our services to meet the needs of that population, we are going to continue to have poor outcomes. So having some of those conversations with teams can be really quite difficult. And again, that comes back to bravery. You need to be able to talk about racism and talk about it in a way that people understand that, you know, there is health inequalities that exist, and we are duty bound to ensure that women and families get the best possible care when accessing our services. And if there's issues with access, then we need to change our service so that they can access, not the other way around. We need to make it easy for people. Next slide, please. At the end of our 2-year improvement programme, what we started to do is look at our key metrics, the stillbirth, brain injury and early neonatal death. And we were tracking this all the way through. And what we found on review is that due to the efforts that we'd made and the changes in pathways that we made, there was no statistical difference in the rate of adverse outcomes by ethnicity. And that is a huge thing to say. Within maternity services as it currently stands. The numbers are small anyway, so that statistical difference can be really, really difficult to identify. But what you've got to do is make sure that you've got the people around you to support you with the interpretation of the data. It needs to be one single message and the data needs to be clear. So is there a health inequality or is there not? And that is the question that we all need to ask ourselves when we are reviewing our data. Next slide, please. We were really lucky within the NCA that, and I'll go back to our BI teams. Our BI teams built maternity. I asked for it because I felt it was important, as did the rest of the team, an inequalities dashboard. And we were the first service to actually launch our health inequalities background dashboard. So what we can do as a service is look at all of our safety metrics, of which there are in the region of 40, and stratify risk and outcomes by ethnic category, so diversity, the age at which they gave birth, what their primary language is, so are they an English speaker, are they not an English speaker, and also their deprivation codes. And what we started to do is look at all of our safety metrics based on ethnicity, deprivation, language that women speak, because a lot of organisations have focused purely on diversity, but actually the main thing that leads to health inequalities is language spoken. And that's the area that you have to focus on. You do have to focus on diversity, of course you do, but the main focus should always be on language spoken, because that's where those health inequalities tend to exist. There's a number of things that we did. So we have interpreters on hand in all of our antenatal and community clinics to support women. We started antenatal classes and antenatal clinics purely for women that didn't speak English. So we would have a group of women that spoke Urdu, as an example, that all came together for their antenatal care with an interpreter present. So straight away trying to look at how we reduce those health inequalities and open up that access. We also introduced open access to triage. Because what we found is women were waiting at home, so they'd be concerned that their baby wasn't moving or they thought their waters had broken, and they were waiting at home for their partners or a family member to come home because they didn't feel that they could communicate with the service. So straight away we removed that barrier and said, you don't need to ring, just come. If you're worried, just come, and there are interpreters that are available to support that. We've now taken that one step further. And we've basically opened triage completely, because my philosophy is why should women have to phone to ask permission to access a service, irrespective of what language they speak, what diversity they are. All our women should have to, if they're worried about something, should be able to attend triage. And we've put a false barrier in there that doesn't need to exist. So that's made a huge difference to our stillbirth rates, because women aren't sat at home with reduced fetal movements thinking, oh, should I ring? Should I not ring? I'll wait for my partner to get home. So it's really important that all services look at how they can remove those barriers to care. And this is just one example of how we look at inequality within our service. So looking at third and fourth degree tears and perineal trauma is just one example. If you just move on to the next slide. We've also looked at emergency.
2 minutes, Faith.
Thank you. We've also looked at emergency caesarean sections. So Asian and Black women, it's the same ratio as our white women, but women who don't speak English have an increased risk of emergency caesarean section. And what you have to ask yourself is why? So what? And again, it's all very well having data, but then you need to understand what you're going to do with it. So we are now using data and this data to drive quality improvement initiatives within the organisation. So 3 messages, I said them earlier: be curious, use your data and be brave. And thank you very much, everyone.
Thank you so much, Faith. An absolutely outstanding presentation. Your key messages are absolutely opposite, but I'd add leadership to that. Clearly, it's your leadership as well, I suspect, that has really driven impressive improvements in a pretty short period of time. So thank you for sharing what you've been doing. We will move on now to our 4th presenter, who is Colin Dunkley, who's a consultant paediatrician at Sherwood Forest Hospitals. And he's going to talk to us about his experience as the lead for Epilepsy 12. And his title is From Incident to Improvement, Using Epilepsy 12 Data to Commission a Safer First Seizure Pathway. Thank you, Colin.
Thank you. It's wonderful to be with you all. And that was your talk about bravery, Faith, has really resonated. I think it's really, really important. I'm going to change the focus a little bit, but hopefully you'll see similar threads in trying to use data to improve things for children. I'm a clinical lead for Epilepsy 12, which is one of the national audits, but I'm going to try and wear mainly a local hat for you today, my consultant paediatrician in Sherwood Forest Hospitals hat, and show how we've tried to react to our local data. And literally, I'm going to show you the hard hat that we've had to wear at times to make some of these changes. Next slide, please. It's nice that we've already had epilepsy referenced earlier in these sessions. It's much more common than you think. For those unfamiliar with epilepsy, it's really one of the common long-term conditions, particularly in childhood, but also adulthood. And it creates a huge amount of unpredictable activity for the NHS. So about 1 in 20 outpatient and ED attendances are related to some type of seizure in children, and it still remains a difficult diagnosis to make. There's no real single test, and so it's quite a complex and predictable group of children to look after and provide for, and therefore particularly difficult to extract data that's meaningful to create change. And we've been thinking about first seizure clinics and services and where they fit in the journey to improve things for young people. And we're particularly interested in the harm downstream around unnecessary activity and avoidable harm, such as things like fetal teratogenicity you've been hearing about earlier, but also unexpected death and learning problems or independence problems. So next slide. And I've been leading with many others the Epilepsy 12 program, which has been going for over 15 years now, and it's one of the HQIP commissioned audits. It's run from the Royal College of Paediatrics of Child Health. We have a group of young people who encourage us and tell us how to improve in the backbone of the audit. And we have clinical audit components, organisational audit components, and at various times we've supported local quality improvement capability from that central base. Next slide, please. And I'm going to try and sort of take a journey from the sort of national picture down into my local data. So you're going to come down from the helicopter to my local view at Sherwood Forest. This is what we've been doing at a national level since we started, produced national State of the Nation reports. Our last one was about a year ago. And each year we look at a succession of children with newly diagnosed epilepsy and try and work out how good their care is. Next slide, please. And at a national level, we produce things like this. So we look at 12 measures of quality over the first 12 months of care, hence epilepsy 12. And we look at a cohort of children from across England and Wales, and we produce a variety of reports. But as well as the national level of reports, of course, we drill down to local level reports. Next slide. And the two indicators that I was going to focus on that we've tried to make difference within Sherwood Forest is around timeliness. So the children reaching the service, the expertise in a timely way. The challenge is to achieve this really within about 2 weeks. And then getting care planning for the child and young person and the parents better and more complete. So the two illustrations I'm going to show you in the next few slides show these two particular issues for us at local level and how we've tried to create change. Next slide. So looking at the care planning area, so this is, do children with epilepsy have the right elements of care planning within the first 12 months of care? And these vertical lines show how each trust was doing in 2019, with some doing really well at 100% and some doing really badly at 0%. And we, Sherwood Forest, were slap bang in the middle with averageness, but we were quite surprised. We thought we should be much better than that. We couldn't believe that something that was so fundamental as care planning we weren't getting right for all our children. So we were surprised despite our averageness. Next slide. And this is a spider diagram trying to drill into the care planning components and try and unpick where we weren't quite getting it right. And it's a sort of cumulative composite type measure, and we were the blue line, and if we were doing it right by all our children would be the orange line. And you can see we had various weaknesses in our delivery of getting these care planning components. So some of them were really quite fundamental about water safety and participation and contact to the service, so we thought we could do better. And next slide. And one of the things that helped bring our data alive was actually meeting as a team, rather than, we were used to meeting as a team for clinical multidisciplinary work, but not for improvement work. So we started meeting to improve and looked at our local data, and it was a really great way to bring the data live and go beyond the data into what we're going to do about it. Next slide. And we jumped on an opportunity. This was looking at data back in 2019, and then we heard about a chance within the trust and with digital knots to begin to connect to families directly through the NHS app with digital in the mix. And we built a service whereby parents and the older young children could message us directly through the NHS app and share videos, which are really important for diagnostics. And we could create individualized information sharing and care planning. So this was our solution we had to go out to try and improve our signal in care planning. So next slide, please. And using epilepsy 12 data, each year we could go back to that same data point. We were able to get really encouraged by seeing how the differences we were making was making a step change in our local data. So it became a really useful tool to support our quality improvement. So next slide. That was one example, and then this next example you can see is a different thing, but is then built on the energy we got from our success with that first one. So this is around how long it was taking young people with epilepsy to come into our service, and we'd had some incidents in the trust where children were too late coming to us, and there's missed opportunity. And then our data also showed that there was an issue with timeliness, and this time in this area we were below average. So most children coming into our epilepsy service were taking longer than 2 weeks, and actually in reality most were significantly longer than this. So we started to thinking, how do we see the children we need to see earlier? Next slide, please. So the opportunity came because our trust was building a new building, and the reality of this is the building actually hasn't done anything, but it created a appetite for change, and because there was energy and funding and looking for updated pathways, we seized on this as a catalyst, and have sort of redesigned our seizure pathway around the building, but in reality it's a bit of a proxy. Most of what we've done is not actually about the building, but we had a new community diagnostic centre being built. It had clinic rooms in the build alongside some of the key investigation services, and already the asthma team were thinking about asthma pathways for children, and there was a national request from the clinical director looking for ways to get children into the benefits coming from these community transformation ideas. And we thought, well, we could use this and we could build on the digital backbone we'd been growing. So this is where our hard hats came in. So we started visiting the building, but also reimagining our pathways. So next slide. And the idea we came up was an offer where, and I think this is where maybe our bravery came in. We would say we would, as a team, move to a position where as soon as possible after we heard a young person had a seizure, we would go to them. So rather than wait for them to find us through the system, we would connect with them, and we began to think, how could we configure our service to do that? What would it look like, such that we reached out to the person as soon as possible, and then began a dynamic relationship with them to guide them through the different investigations that they might need to get to the diagnosis, and then beyond. So we came up with this First Seizures With You pathway, and I'll just walk you through the notion of this. Next slide, please. So this is going to look like a bit of a sandwich with the two slices of bread. What we do at the moment, and then the filling is going to be the new pathway in the middle. And what we were worried about is if we simply created a first seizure clinic and said we would see all these children with a first seizure, we'd feel like we're doing great things, but we'd be overwhelmed and end up seeing children who didn't really need that type of attention and were beyond our capacity. So we thought, what could we build into the existing pathway, which would keep the same inputs, children coming either acutely or non-acutely, or and then coming out into different types of service at the end. What could we do in the middle to create a bit of cleverness? Next slide, please. And so the resource we went for was I think probably best understood as an enhanced triage type function, where we connect to the patient and then we dynamically interact with them, such that we triage them towards an earlier diagnosis where appropriate. And we employed a new specialist nurse. We got additional clinic time, and we built a capability in the filling of this sandwich. Next slide. And we started tracking patients in ways other than just seeing them in clinic. We created different ways to do things other than just see them in clinic. So investigation only pathways, video review pathways, advice only pathways. And we started seeing children in a dynamic and individualized way before they were even seen. So it was lots of discussion and connection without traditional touch points for review. Next slide. So I'll just show you some early data from this. I think we're doing really well. It's completely changed our perspectives. So we've been accepting children onto the pathway since December, and we've now appointed a substantive specialist nurse on the basis of data and ambition we've achieved so far. Next slide.
Colin, just a 2-minute warning.
Yeah, that's great. So this is our new building. It opened in April. Next slide. And we saw our first new person in that building in April. Next slide, please. And by May, we'd accepted 80 children onto the pathway. Next slide, please. And these were coming from everywhere, as you might expect from what I talked about, the way children present, from outpatients, but also from ambulatory and ED. And the interesting thing was that most children we didn't need to see in clinic. So most children we weren't actually seeing face to face. We were deciding who needed EEG. We were reviewing their EEGs. We were reviewing video. So we were able to do a lot outside traditional clinical activity. Next slide, please. And so far, about a quarter have been diagnosed with epilepsy, and the other quarter we've confirmed that not epilepsy, and then others we're still brewing to work out what the diagnosis is. And then next slide. And some children are still active in the pathway and some are still inactive, but we're beginning to get flow through this new pathway. So, and then finally, so we think we've developed something fairly novel here in terms of doing some dynamic enhanced triaging to solve a problem, and we're trying to build now some capability in terms of doing faster investigation routes using the CDC resource. We're going to use our ongoing Epilepsy 12 participation to hopefully evidence improved outcomes in that space, and we're going to think how could this help other neighbourhood pathways as a model. And then finally, it's been interesting. The national audit is really a local audit, and it's really helped us see gaps and direct local change, and it's really helped us create that change locally and evidence the business cases we've needed. And it's been challenging. We enjoyed putting on hard hats, but it's been satisfying along the way, and who knows where it'll lead. Hope you found that interesting, and thanks for your time.
We certainly did, Colin. That was a fantastic presentation. And again, another great example of improvement at a local level, lots of top tips, and you know, how you manage this in a real world setting. And probably the most important thing in the NHS being opportunistic, isn't it? You saw an opportunity and you took it. And we all know of our examples where we've done that and what benefits it brings. Okay, we're nearly there. We're on to our fifth and final speaker, who is Claire Wade, Director at the Patient Safety Learning. And she's going to give us an update on the work of her organisation. We've cruelly only given her 5 minutes for that update. So Claire, I'm sure you've got lots to tell us. Following that, we will have all of our presenters as a panel Q&A. So keep those questions coming. Over to you, Claire.
Thanks, Jackie, and thank you, HQIP, for inviting us here today. I hope everyone is holding up under the heat. I'm here to do a slight shift in momentum. Some great presentations this morning. Really enjoyed listening to colleagues and their improvement work. So at the end of a really good couple of hours, I'm here to offer you something free, and that is always a positive thing. Next slide, please. So, as Jackie said, I am the director of a very small charity called Patient Safety Learning. We were founded in 2018, and we kind of do what it says on the tin. Everything that we work to achieve is to improve patient safety throughout healthcare, not just the NHS, but throughout all healthcare. Next slide, please. And what drives us, what gives us the sort of passion every day to keep doing this work are these kinds of statistics. So over the last 20 to 30 years, such a lot has happened in the area of patient safety, but unfortunately, the figures largely remain the same. And I think if the public, the wider public, knew that patient safety isn't always a priority, they'd be very surprised by that. Next slide, please.
So right back when we very first came to be in sort of 2018, 2019, we wrote our blueprint for action, and that is still available online if you'd like to read it. And I'm not going to go through all of these points, but it largely demonstrates and evidences why avoidable harm persists. And there's not just this list here, there's a whole list of issues linked to culture, linked to leadership, linked to investigating incidents, but then the learning not really being there, or the learning not being shared and acted upon. So a lot of reasons why so much work has gone into patient safety, but why those harms still persist. Next slide, please. So we really believe that in order for patient safety to improve, it must become a core purpose, or it must remain a core purpose. And that's at all levels, whether that's policy, whether that's through commissioning, whether that is on the ground with the people who do the sort of care day-to-day, service provision, professional regulation, and really importantly for us, patient and family engagement, and actually credibly and honestly involving those voices in all that we do. Next slide, please. So how can we help you? One of the big sort of achievements for patient safety learning is the hub, and the hub is an online platform. It's free for everybody to join, whether you are in healthcare or a patient or a family member. The link is there on the slide. You can visit that at your leisure. And since 2018, it has grown, and it's now the world's largest repository for patient safety materials. We have a whole host of free information on there. We also on a daily basis share the news that is in relation to healthcare, and we also host several networks and communities which again are free to join, and you can interact with these communities in as small or as large a way as you would like. They all meet with varying regularity. Our largest network is our Patient Safety Manager Network. That meets every Friday in the afternoon, and it's grown from having 4 members to over 2,000. And we regularly have 150 to 200 members on those discussions every Friday afternoon. Our Associate Director, Claire Cox, hosts that network, and she works really hard to listen to members and to bring to those meetings speakers who will share, will help people to learn. The networks are also a great place for peer support. We have discussion forums, and we really encourage people to share their learning and sort of disseminate that knowledge. We like to think that it's the voice of the patient safety frontline. We're always looking for people to join us. We're always looking for people to share with us what they're doing. And we are very happy to share that on the hub so that members can access that for free. Next slide, please. So a little bit more about the networks. As I've already said, we have the PSMN, the management network, we have patient safety partners, we have a patient safety education network. We host 6 at the moment, and there is a lot of appetite to grow. One of the new ones that we're looking at extending into is GP and community practice, and that's part of the 10-year health plan shift into neighbourhoods. So it's a really vibrant and energetic place to be. Lots of support available at the networks. So I would really encourage you to visit the hub, have a look at the networks, join up if you want to, and come along to meetings. Next slide, please. So how can we help you to help us? As I've already said, learn and share. The hub is a great community for sharing that learning. We host topic experts, topic leads. So it's a voluntary role, and it's absolutely up to the topic leads in terms of how much time and effort you want to put into it. But we're always on the lookout for people who have expertise in an area of healthcare, and want to share that expertise, share thoughts, share work that they might be doing with the wider community. So if you're interested in becoming a topic expert, my email address is there. Please feel free to get in touch with me. We also, on a pretty much daily basis, publish blogs from people. So if there's something that you're really burning to get out there, some information, some learning, and you would like to write a blog for us, again, get in touch, let me know the subject. We have a very small sort of comms and engagement team, but we have an editor, and she will very gladly be in touch with you to support you writing your blog. Our website, also the link to the website is there, and we are very close to launching our new updated website. So please head there as well to have a look for more information about us. We're also on LinkedIn and Blue Sky. So yeah, that is about us. I will hand back to Jackie. Thank you.
Thank you so much, Claire, and a fantastic update on the work you do, and a really important reminder of how important the BCSE sector is in the patient safety landscape. So it's a really great way to end our speakers today. Right, we're going to move on to our quick question and answer session that we've got at the end. I'm going to hand over to Lacey, my colleague at HQIP, who has been scanning the Q&A box and has got a few lined up for all of our speakers. So be ready. If she says your name, then it's over to you. Thank you.
Thank you, Jackie. I'll do my very best to cover something for everyone, but with apologies up front because we've had so many fantastic questions, and we simply won't get through them all, but we will address them after this event on the HQIP website. So, firstly, for Henrietta, I'd like to make a quick observation that for me, the most powerful thing about Martha's Rule, it won't surprise you that Martha's Rule came up a lot, is the fact that it's an opportunity to move away from the expectation that we get things 100% right all of the time, but instead that we focus on learning, and in particular, learning before things, before we pay the ultimate price. So I'd love to hear your thoughts on that. But also, there's been a couple of questions around community rollout of Martha's Rule, and did you have any information on that?
Yeah, well, thanks very much. And, I think this is about working in partnership with patients and seeing that everyone has really valuable information to share that can be towards a common objective. And I think what's been really interesting for me around the use of Martha's Rule by staff is that previously they had to follow the policy that said if the news score was normal, you couldn't pick up the phone. And we know that the news score is really great, but it doesn't cover a lot of conditions. And young people in particular can have really quite good, observations and then suddenly crash. So freeing people up is what this is all about, and being extra pairs of eyes and ears to really support early intervention. In fact, you were saying about getting involved before people pay the ultimate price. And I think what's been really interesting is hearing from medical examiners. So there are some medical examiners who, because of their roles, also take the calls from Martha's Rule. And one of them said to me that the similar themes come up in the conversations they have with families as a medical examiner as they do when they're getting a call around Martha's Rule. And I think what's really important is to have those conversations with the patient and the family at the earliest stage. And that may also be that the patient is dying, but it's making sure that everybody's aware of that so that they don't have unnecessary and really, undignified interventions at the last point in their life. In terms of the rollout into different areas, these are being led by NHS England. So I've heard around, questions about community, about mental health, about emergency departments. You know, and I think what's really important is that we consider already what are the existing escalation routes that staff have, and what are the existing escalation routes that patients and families have. But also, I suppose, as clinicians, there's something about us always remaining curious. You know, if somebody's coming back again and again, and we have this in primary care with Jess's rule, we need to just think differently, and maybe bring in a colleague, have a conversation. What are we not seeing? What are we not hearing? And maybe the decisions that have been made before are channeling us down a particular route. So I don't have any specific information about community services, but I can see a host of reasons why we would want to create the right opportunities for patients and families and staff to be heard in all settings.
Thank you. Thanks very much. Next for Chris, there's quite a specific question around to what extent does NJR data insight, to what extent is it linked to hospital level visibility? And does it contribute to or inform hospital league tables?
So transparency of NJR data is something that is very important to us, and we think the patients should have information about the performance of services. So we have a website, so it's the NJR Surgeon and the Hospital Profile website. Anyone can look at that, and it will tell you the activity and outcomes of every hospital and surgeon in the country. I think it's important to be cautious around ranking organizations on metrics like this, and particularly ranking individuals on metrics like this, so we don't. But I think that it's important that patients have enough information to understand the safety and effectiveness of the services that they are choosing to go to.
Right. Thank you. Sorry for such a whistle-stop tour today, but we just whipping through them, and we will forward all the questions afterwards. For Faith, it won't surprise you that a lot of the questions are around healthcare inequalities, and there are two specific questions which are linked around footfall. So, did you see increased footfall when you removed the need to call from door to triage? And if so, were there any concerns or issues with resourcing or staffing for that?
So I suppose the short answer is yes, but it does settle back down, and I don't know whether or not I am happy to share data if people want to contact me directly, but it's absolutely having the right triage model in place and make sure that you're using the tools and the BSOTs methodology to prioritise those women. I think the issue is, and this was some of the concern that was raised from the teams, well, we're going to have all these women turning up and it's going to be horrendous. But my response was, well, those women need to come, and they're worried, so they need to come. We do still have the telephone line, and some women will still use the telephone line and will go through the standard triage process. But removing that barrier has absolutely helped women that historically may not have come attend in good time, and we've seen an improvement in our outcomes, and we've maintained that performance with our BSOTs for triage in terms of those KPIs. So yes, you will, but my view is, well, those women probably needed to come anyway. All we've done is remove that barrier. But you've absolutely, as well, as you say, got to get that workforce model right. So we have 3 midwives, so 5,500 births a year. We have 3 midwives, plus a telephone triage midwife 24/7. If something's going to go wrong, it's going to go wrong in triage. So you've got to get that staffing right.
Great, thank you so much. For Colin, there was a quick question around the rationale for securing recurrent funding. Any thoughts? People are obviously always interested in how they can obtain funding.
Yeah, it was a tricky, to be honest, and we've had to make a step of faith. I mean, the current way activity is seen and priced doesn't really suit, in my mind, the NHS plan and this left shift towards activity, certainly when it's delivered from an acute trust where you're trying to do things before appointments or in between appointments, and so at the moment we've had to do it on the assumption that we will reduce ED attendances and necessary admissions and the necessary epilepsy medication, all of which are expensive and cost the system, and that the neighbourhood pricing will in the end help us solve this in the system. But as a as a player, it was a difficult business case to get over the line, and essentially it's come down to doing the right thing, and then hoping the data and the economics can work in our favour later on. But it's been really tricky. But the epilepsy 12 data helped, and then capturing our local data as we did the project helped us as well. So that was part of winning the argument.
Great, thank you. And with moments to pass before Jackie loopholes me off the screen, a quick last word from Claire around any thoughts on the work that you've been doing applied to mental health. A few seconds, please.
So from a point of view of mental health, I think it absolutely weaves its way through every specialty, doesn't it? And through every interaction with patients, actually. We feature right across the healthcare landscape, and mental health is something that comes up time and time again, whether it's within our networks and discussions, whether it's through the patient voice and through representation and inequalities. So whilst we drive across the healthcare landscape in terms of the presenters that we have at the networks, the information that we share on the hub, mental health, I would say over the last couple of years has been for us quite a central theme, and we're very aware of the fact that in the last decade or two, funding around those services has sort of slipped away quite significantly, and the repercussions of that are obviously seen throughout healthcare, in EDs and social care, with the inquiries that we see unfortunately into incidents that have happened. So it's a key area for us to highlight and to share information, good practice, improvements, and it's something through our policy and influencing that we are keen to highlight as an area that needs reinvestment, across the NHS.
Thank you so much. And back to you, Jackie.
Thank you very much, everyone. And that's us. We're all done. What a fantastic session, of course, made possible by our brilliant speakers. So huge thanks to the 5 of you, but also for having a really engaged audience as well. Some great questions. And over 370 people on the call at our peak. So thank you all for attending this and no doubt other events this week. As we said a few times during the webinar, we will take the questions you've posted and distribute them to our speakers or to our internal experts at HQIP. And we will post them on our shiny new website. HQIP have a new website, which is fantastic. I ask you to have a look at it and have a play with it, and also have any feedback if you want to. So all our resources will go there. As you know, this is a week-long campaign. So we've got one more day of Clinical Audit Awareness Week. We have 2 events on data-informed improvement tomorrow. And if you want to attend, you've got the QR code. Or if you go onto the HQIP website, I'm sure you'll see the joining links there. So just another enormous thank you. We'd really value your feedback from this webinar. So again, a QR code on the slide if you want to scan that now and give feedback, or for those of you that are watching back, we don't have a close date to it. So please do feedback. Or else there's a form on our Clinical Audit Awareness Week page on the HQIP website. So thank you all again. Hope to see some of you tomorrow on our final day of the campaign. And thanks for sitting through an hour and a half in a rather hot and sticky office, no doubt. Have a great rest of the day, and thank you.